Like,
ಕೇಳಿಸ್ಲಿಲ್ಲ.
Okay.
Ready, ma'am? Ready, ma'am?
Shall we start now?
Yeah, ma'am. Ready, ma'am. Kindly process.
Yeah. Good evening, all. Hello, namaskar. It's a moment of extreme pleasure to welcome respected Chief Guest Dr. Subramanya Sir, Guest of Honor Dr. Swati Bhave Ma'am, President Dr. Gangolia, Secretary Dr. Amol, our renowned judges Dr. Aarti Kinikar Ma'am and Dr. Nani Wadikar Sir, all the dignitaries of Maha-AP, our colleagues and today's speakers and dear friends who have joined today. We, as a part of Women's Committee of Maharashtra IAP, which was formed on 38th of this January 2022 at Nasik EB meeting, we have formed this our group to have this activity as Tuesday Takes for the next 9 months. Every third Tuesday of the month, we will be conducting this program. Actually, I have once we had formed the EB of MahaAP, I had requested Dr. Gangolia ji and Amol ji to the have this concept, and I have forwarded to him my ideas, and he said ki Renu, you should design, coordinate and get it implemented, and if you need any help from us, you take it from us. That is what then we thought. I thought that women's committee is formed, so why not we take the help of all our lady friends and the esteemed renowned academicians of our group. And so we, as Women Committee of Maharashtra IAP, has formed this Tuesday Takes as the first program today. It is a glad welcome we bring to you this evening, filled with desires, hopes, and dreams we all share in pediatrics in the form of this Tuesday Take program. The Maharashtra IIP Women's Committee are delighted and excited about working as a team starting from today with this program Tuesday Takes. The entire office welcome you all, and we hope to have a long and successful journey together for the next 9 months that will be conducted every third Tuesday with new topics, new speakers, and new judges. And mind you, it is not gender biased. We are having equal male and female representatives as our colleagues. We are at par with each other, and so we take it a pride feeling that our gentopedia and ladypedia that we say with a सो प्रेमाने आम्ही म्हणतो जेंटोपीडिया आणि लेडीपीडिया, तर असे आमचे हे गुंतून आम्ही एकमेकांबरोबर काम करणार आहोत, आणि तुमचे हे सगळे आशीर्वाद आमच्या बरोबर राहू द्या. And now I would like to call upon our MahaAP President, Dr. Gangolia ji, to express his view on this occasion. Dr. Gangolia ji, can you please unmute yourself?
Thank you, Dr. Deepa. Respected dignitaries, Chief Guest Dr. Subramanya Sir, Guest of Honor Dr. Swati Bhave Madam. It's a very great pleasure to have you all respected faculties, dignitaries, judges, Madam Aarti, as well as Dr. Nani Wadekar. It's a very great pleasure to have everybody. Just because I'm traveling, probably my audio will not be good, but all my best wishes to this Maha Women Committee. They have started doing the wonder works, and thus they have gone and made the project, and Here we see the first show of Tuesday Takes, and it is totally inspired by our chief guest ideas of T20, what we witnessed at Amravati. Sir, you are the inspiration for us. Mini T10 or mini T20 for that matter. Let's see how it works, and you are there to guide us. With that, my all the best wishes to each and everyone. All the best wishes to the speaker as well as
Thank you so much, sir. I would now request Dr. Amol to kindly express his views. Dr. Amol, as a secretary of MahaIP.
Anyone. Good evening, one and all. Good evening, today chief guest, Dr. Subbu sir, who is Vice President, Central IIP West Zone, and guest of honor, Dr. Swati Bhave ma'am, who is patron of MahaIP Human Committee. On behalf of Dr. Hemant Gangalia sir, who is traveling and his network is not good. So on behalf of President sir and team MahaIP, I congratulate Dr. Renu Boralkar ma'am, Chairperson, Women's Committee, MahaIP Women Committee, and Dr. Sonali Shirvate ma'am, Co-Chairperson, Women Committee, and entire team of Women Committee for taking up this initiative of Tuesday Takes, which will be helpful for all the general pediatricians in their day-to-day practice. It is very innovative idea which will set many milestones in yearly MahaIP academic activities. Thank you once again. Over to you, Renu ma'am.
Thank you so much, Dr. Amol. Now, what is the surprise of today is our Dr. Suppu sir that we lovingly call him. So I am profoundly delighted to take an opportunity to introduce our chief guest for the evening, Dr. N.K. Subramanya, who is the Vice President, South Zone 2022, and a renowned pediatric pulmonologist. And मराठीमध्ये अशी म्हण आहे, मूर्ती लहान आणि कीर्ती महान. तर सरांचा एवढा मोठा महान सीव्ही आहे की मी तरी वाचण्याचा थोडक्यात प्रयत्न करते. सर इज करंटली मेडिकल सुप्रिटेंडेंट ॲट सप्तगिरी इन्स्टिट्यूट ऑफ मेडिकल सायन्स अँड रिसर्च सेंटर बँगलोर. He is South Zone Vice President 2022. He is teachers for last 25 years for UG, PG and the examiners for them. He is chairperson IIP National Respiratory Chapter. He is national resource person for ATM asthma training module, ethics module, RTI GEM module and many more such modules. He has organized many CMEs, workshops and conferences at district and state level. He has many publications in textbooks of pneumonia as well as articles in index journals. He has been faculty at many conferences. That is a very huge list for district, for state, for national and international conferences. And hats off to you, sir, for your great achievement. And also he has been got many awards for the as best secretary Karnataka state, and prestigious orations were given by him like Srimati Parvatamma Halappa oration, Lakeside CME 2020, Pedicon 2010 oration at Andhra Pradesh, Dr. Dharma oration at Midterm Maha Pedicon Kolhapur 2021, and active. He's so much active in many social pediatric activities, and also his videos of respiratory things are famous on YouTube, which we all common pediatricians follow. And now I request Honorable Chief Guest Subramanya sir to address the gathering and cast the knowledge upon us. Sir, over to you.
Respected teacher of teachers, very senior pediatrician, and who inspired many youngsters like me, respected Dr. Swati Bhave madam, I'm starting from you because you were the mother of those quizzes which I won once upon a time when I was an undergraduate and as well as when I was in practice. So therefore, we in those stages looked upon you, madam. So if I am there today, it was because of pediatricians and senior teachers like you who took us through all phases of life. And respected President Hemant Bhaiya, and my dear treasurer promoted secretary and will be promoted president, Dr. Amal Pawar, our Jay, Sanjay, Deepa, Nanvekar, Kaustubh, Aarti madam, who has worked with me in PG teaching modules, apart from she is head of the department at the institute where I got my MD. But having set the trend, I'm not taking all the names. Sonali, you are so nice. And many more, Dr. Neha, Dr. Amruta, Dr. Preeti, and many friends from Maha IAP. Let me tell you, I am not guest. I am member of Maha IAP. This is the privilege that you have given to me, and I will continue. And if there is any fees, I am ready to pay. So this is the kind of feeling that I get from Maharashtra IAP. I'm the only faculty for all the Mahapedicons in the last 11 Mahapedicons. That shows the amount of affection that you have bestowed upon me. Maybe it will become a record for my lifetime. I'll be there in all the Maha-IAPs. I'm promising you. But Swati madam, in front of you, let me promise that in every Mahapedicon, let me give some new ideas. This idea was floated that mudde pe aa jao, no bakwas. Because when we give 45 minutes also, they speak the same thing. When we give 20 minutes also, they speak the same thing. And when we give 5 minutes also, they speak the same thing. And the speaker, when he gets down the stage, will always tell that I should have got more time. You know, that feel will come. I think every one of us who have spoken will realize that. But if we speak correctly and appropriately, anything would be nice, because we have enjoyed test matches. We have enjoyed one-day matches. We have enjoyed half-day matches, T20, and in next we can even have 10 overs. And we have enjoyed some people who have made 36 out of just 6 balls. So the point is not about academics. The point is about entertainment plus academics. That is possible when the time is limited and the performer has to give his best and his energy levels are his best. And the attention span of everyone would be fantastic. This is a small exercise, and let us get up. You know, I don't want anybody to relax. Those of you who are presenting for short period of time, make best use of the time, and it should be the best presentation in the life. It should be a lifetime achievement of you in those short minutes. And I will tell you, this gives the fantastic academic kick. And impact factor, if you take from me, lesser the time, more is the impact. Longer we speak, less is the impact. So therefore, I'll tell you, do not feel, even if you cannot complete 3 or 4 slides, doesn't matter. But what you speak, how you speak, how voice modulation, what kind of voice modulations you have, and what is that you want to give as an impact, you know, that should come. And there will be an academic surprise as to what will be the next gift in Mahapedicon from me, with a new idea, which I have already formed in my mind. I'll share with the next organizers. Let it be an academic surprise for all of you. And we will see that every Mahapedicon will be Neo Pedicon. Renu, let me lastly tell you, fantastic move from Women's Wing. You told 9 months program. It will be a full term normal delivery with a crying baby at the end of 9 months. And let me tell you, this program will grow trimester by trimester, day by day, and will reach a complete successful contented motherhood feeling, which is the greatest gift. We are actually jealous of women for the tremendous patience that you have got in life. And I'll tell you, women are always successful, and men are always successful if they have a woman. So it's always like that. And let me not take any shame in complimenting the women force. And because of you people, and I still remember, let me tell a small joke. In residency days, you know, it's always the girl PGs who used to do maximum work, and boys used to just come take rounds and chalta hai. I think all of us smile and remember and acknowledge. They used to write case sheets, everything, all the care. Now I can see Kaustubh nodding his head. I think you truly agree, no? Yeah, we used to always chat and move around, even in KM Pune and Bija Medical when I was studying, it was the same story. Hats off to your patience. Hats off to the perseverance that you have got. There is a lot to learn from every one of you. And maybe I have exceeded my time. Being a chief guest, I thought it's a privilege, and let it fill the energy amongst the contestants. So that was the idea, and therefore let me not take away much of your time. Even I want to enjoy the sessions, and maybe I'll come in between with the permission of the chair, and add some spice if at all I can. So let's have a great beginning, and over to Renu for and all the best for all the sessions. Please send me the links. I will not be, even if I'm not, even as an audience, let me enjoy all the Tuesdays of yours, and let's make our life blissful. And thank you. Being an academician, we love the way that you are presenting yourself from Maha IIP. Thank you very much.
Thank you so much, sir, for your kind words. We are very grateful that you have joined today to our invitation. Now then, I will call upon our gorgeous lady guest of honor, Dr. Swati Bhave ma'am. She is patron Maha IIP Women's Committee presently. Her CV is as follows. She is adjunct professor adolescent medicine at D.Y. Patil Medical College, Pune, visiting adolescent consultant BJ Medical College, and also at Jahangir Hospital. She is executive director Akki, which is an NGO run by her with her group Mumbai. I am also a member of that, and very nice programs are conducted by that. She was the IAP president 2000. I think she is the only woman president, I think, in history of IAP. So hats off to you, ma'am. And member of WHO TSC. She has won many awards, of which the most important prestigious is the IAP Lady Pediatrician of Millennium 2000. IAP SS Oration was given by her in 2020, and she got a Lifetime Achievement Award IAP RCH. Ma'am, over to you for your kind words for us.
Thank you, Renu. I really enjoyed the chief guest address, Subramaniam, and thank you for your kind words. Praise from another academician of your standard is something really I value, and it was nice hearing you. Let me thank Renu, Sonali, and all the women members of Maharashtra IIP for calling me as the guest of honor, and Amol and Hemant also. And especially because my very favorite student, of which I'm very proud of, Arti is the judge, and Nanudekar, the second judge. I've worked with him since past days in 1987. And I can see many familiar faces here. I want to mention Chitra Kulkarni and all these people. Lovely having all of you. It's a pleasure to see such active women in Maharashtra IIP, and their energy is amazing. And as Subramaniam has said, every third Tuesday you're going to have a academic feast, and that will be something really to watch for. Deepa Firke, I forgot to take your name. And only thing I wanted to tell you that, at my advanced age, I'm trying to follow a healthy lifestyle. And one of the thing is not to have screen time as much as possible after 8:30 and sleeping at 10 o'clock. Because I give corporate motivation lectures for healthy lifestyle and digital media diet. So you will excuse me and if I don't attend the whole session. But normally what I do is I see the recorded sessions during the day. So Renu, a very request to you, please keep sharing the recorded links, and I would love to go through these programs during the morning. And I think it's a fantastic idea. I mean, the ideas that you're having judges, you're having youngsters presenting cases, and I'm really honored that you have made me the patron. And you can't say no to Amol. When he phones, you have to say yes. So today was a really hectic day, but I just could not say no. So thank you very much. Look forward to the women power in Maha IIP. And Amol, I took more than half an hour to go through your program of Maha IIP. And I don't know what to say. There's an academic feast, social, cultural, every possible aspect covered. Now this Tuesday Women's Program. I'm sure you're going to get the Maharashtra State Best Chapter Award, a Best State Award in IIP, and I'm sure you all deserve it. So with these few words, thank you very much. Let Maha IIP keep flying high, and the women power of Maha IIP, all the young women, and I'm sure you'll do very well. Thank you so much.
खूप खूप आभार मॅडम, तुम्ही खूप सुंदर बोललात, आणि we know health is wealth, so you are excused from this program if you feel whenever you can go, and we can share recordings with you, ma'am. And thank you for your blessings and guidance.
I love to see the recordings. Yeah,
ma'am. I now request Dr. Jay Bhandakar, who is the state convener of MAHA-IP, to have express his feelings about this program. Dr. Jay, can you unmute yourself, sir?
Yes. Thank you. I will say thanks for मला थोडं बोलण्याची संधी दिल्याबद्दल. खरं तर सचिन तेंडुलकर डॉट ब्रॅडमन आणि या मॅडम बोलल्यानंतर मी बोलणं म्हणजे थोडं चुकीचं आहे, पण एकच म्हणणे की वुमेन IPL पण चालू होतीये. ऍज अ स्टेट कन्व्हिनर तुम्हाला फुल स्कोप आहे. आता ही सुरुवात आहे. नॉट 9 एपिसोड, यू कॅन एक्सटेंड ऑल्सो. मेनी एपिसोड्स इन बिटवीन काय वेगळे असतात. आणि ऑल द बेस्ट फॉर द फंटास्टिक. अँड आय टोटली अग्री विथ सूर्यनंद सर. यू शुड बी एंटरटेनमेंट अँड अकॅडमिक्स, राईट. सेम स्टाईल ऑफ मला वाटतं प्रेझेंटेशन किंवा हे काय काय बोरिंग होतं, पण what I started the quiz, Bollywood quiz Premier League, everybody witnessed that. We are going to do this year also. So all the best. Thank you, Amal, for giving and Renu madam for the opportunity to speak in for the men in the women's committee. Thank you. All the best.
Sir, you are the state convener. It is your own platform, so there is nothing like that for
No,
times.
I have not included your WhatsApp group by these two
Are
videos.
no, no, sir.
तक्रार आहे का?
MAHA-IP,
मॅडम ती
all the
तक्रार
MAHA-IP.
समजून तक्रार समजा आता त्यांची ती.
ओके,
चेष्टा करतोय.
ग्रुप मध्ये नाहीये म्हणून त्यांना राग येतोय का? सॉरी सर. वी विल टेक यू इन द ग्रुप.
No, he will be crushed in the group. Don't go there.
He will sing songs.
Okay.
Yeah, thank you. Thank you so much, sir, for your kind words, Jay, sir. Now, I will introduce Dr. Deepa Firke, who is also our co-program coordinator of today. Madam Deepa is Associate Professor at RSCM Medical College, Kolhapur. She is ex-EBM MAHA-IP 2021. And presently, she is Women Committee Zonal Member, Kolhapur. And she will now be conducting the next session. I will hand over to her for the next session proceedings. Over to you, Deepa.
Thank you, Renu ma'am. So, good evening, everyone. I'm Dr. Deepa Firke. And yes, I welcome you all to this interesting and an innovative session. You may call it a bullet train or a whirlwind or maybe a roller coaster. But we assure you that it will be definitely a thrilling and an exciting session. In this journey, we'll be navigating you through various common symptoms and signs that we encounter in our day-to-day practice. And for this, we'll be having speakers from the different parts, different zones of Maharashtra. And they will be guided by our academic judges. And today we have the honor, the West Zone has the honor to host this first session. And we have with us today the Stupendibulous Six. And I will also call them the fast and the curious because they have to present in just 5 minutes. So I welcome them for this session. And yes, and equally enthusiastic judges who are definitely enthusiastic as well as hardcore academicians. I welcome Dr. Aarti Kinikar ma'am. She is the professor and HOD of BJ Government Medical College. She's also the member for the Pediatric COVID Task Force of Maharashtra, and she's done a commendable job in the recent COVID times. She's also a national and international faculty. Our next judge, we all know it's our own Dr. Narendra Nanivekar sir. He's the executive board member for Central IP 2021 and 22. And he's also the national convener for IP, ALS and BLS. So I welcome you both for this session. So the time is clicking, the clock is going, and so without further ado, let's start with the session. We all know that immunization is the bread and butter of all the practicing pediatricians. But we must agree to it that the AEFIs, that is the adverse effect following immunization, is many a times ignored. And we do not report these AEFIs properly. So to impress upon the importance of AEFI, may I call upon Dr. Prachi Patel, who is a consulting pediatrician from Aurangabad. Dr. Prachi, you can please start with your talk.
Yeah. Your time starts now, Prachi.
Good evening, everyone.
You can you can go for the slideshow mode, Dr. Prachi.
Yes, I'll do that. Thank you. Good evening, everyone. I'm going to talk on adverse effects following immunization. So let's start with two case scenarios. In the case study 1, we have a 2-month-old male child who had come for DPT vaccination 24 hours back, now complaining of fever, local swelling. In the case scenario 2, we have a busy pediatrician. While reconstituting measles vaccine, he breaks the ampoule of the diluent. He asks his staff to get another one. The staff, being new, doesn't know and gets another ampoule kept in the fridge. The child is brought unconscious after half an hour. So these two case studies reflect the wide spectrum of AFIs which we see in our day-to-day practice. So what is an AFI? An AFI is an adverse effect following immunization, which is an untoward medical occurrence, which does not necessarily have a causal relationship with the usage of the vaccine. It can be an unfavorable sign, symptom, a lab finding, or a disease. So they can be of two types: minor, as in case 1, which was short-lasting, resolving spontaneously, local or systemic; serious, if it results in death, is life-threatening, resulting in permanent disability, requiring intervention, as you saw in case 2. So as everyone knows, there are 5 major classes of classification of AFIs. Vaccine product-related reaction, which is because of the inherent properties of the vaccine; vaccine quality defect-related reaction; immunization error-related reaction, one of the most commonest cause of AFIs, also seen much more with mass campaigns; immunization anxiety-related reaction; and a coincidental event. So how to prevent? Maintain proper cold chain, use proper vaccine and proper route, do not store any other drugs in the fridge, do not use any other diluents than specified, and follow safe injection practices. Please remember, every pediatrician should have following minimal essential things to tackle the anaphylaxis. That is, adrenaline injection, ambu bag, oxygen, and hydrocortisone injection. Now, the AFI surveillance is an important part of this. Role of surveillance. It is to detect, report, and respond to AFI promptly, identify the problems leading to the reactions, preventing false blame arising due to AFI, raise awareness and nullify public concern, and causality assessment. The goals of AFI surveillance is to minimize the negative impact of AFI on public health, to monitor the quality of vaccine, ensure that proper immunization protocols are followed, reduce morbidity and mortality due to AFI. Please remember, AFI surveillance is not to blame anyone. So the questions arising are: when to report? Within 24 hours of the complaint. What to report? Any serious AFIs, events associated with the newly introduced vaccine, AFIs that must have been caused by an immunization error, events of unexplained cause occurring within 30 days after a vaccination, events causing significant parental or community concern, and swelling, redness, soreness at the injection site if it lasts for more than 3 days. How to report? Remember to keep the local medical officers' phone numbers in handy. Preserve the label and vial of the vaccine. Very important to maintain the temperature chart and the patient details. And whom to report? We need to report to the local medical officer of the primary health care center, who in turn reports to the district immunization officer, followed by the state medical officer. And in doing so, we have come across certain forms, that is the case report form, case investigation form, which is preliminary, and the final case investigation form. So the take-home message would be: reassure parents that sometimes vaccine can cause side effects. Don't be afraid to report. Train the staff, keep the emergency kit ready, and be aware of the AFIs. So the AFIs are identified by existing surveillance, and this is just the tip of the iceberg. Thank you very much.
Thank you, Dr.
In
Prachi.
time. Yeah.
That was definitely an excellent and informative talk. Now I would request Dr. Aarti Kinikar ma'am. Ma'am, you have been the part of the team for the inspecting team that visits for serious AFIs. So can you just tell us what are the frequent fallacies that we see in reporting the AFIs?
Thank you, Deepa. At the outset, let me thank Maha IIP Dr. Gangavalia sir and Dr. Amol, and I am honored today to have Dr. Swati Bhave madam and Dr. Subramaniam sir here for this session. So coming back to your question, I have been associated with the state AEFI committee since 2000 and now as a chairperson. So when we look at the AEFIs that have been reported from the community or the hospitals, primarily we do a causality assessment, whether that reaction is because of vaccine, is it an error on somebody's part, or it is totally not related and the vaccine is unnecessary, blame for it. So it goes a rigorous process which is there. And what we find is, first thing is people are afraid of reporting, especially Maharashtra is under-reporting minor AEFIs. And one needs to remember that over the last many years, new vaccines have been produced which are much safer, basically by overcoming the AEFIs. So if you don't report a AEFI, you are not going to get safer vaccines for children. So the fallacies which come is, one is that when you report, there are many parts in the form which have been left blank. So when we are doing the causality assessment, we don't have the patient or the doctor in front of us. It is all based on the reporting what is done. There are certain timelines that the first report has to go in 24 hours. Then the district immunization officer assesses it and sends it to the district level, and from there to the state, and then it goes to the national level. Now, all this is time bound and it has to be completed within a time frame. So from the site in the periphery, when it comes to us, if it is late, then everything goes late. Today, we have over 300 cases that are pending for serious AEFI. So you can imagine how much problems are there in the forms which we get through. So that is one where we need to write each and every part of the form. If you are having problems, contact us at the state level and we will guide you how these forms are to be filled. The next part which comes is whenever there is an adverse event, there is a lot of repercussions in the media as well as in the community, and doctors are afraid it will affect adversely their practice or themselves if there is an adverse event like a death. So if we want to remain safe, what we have to do is follow the precautions of prevention. That is the correct vaccine, the correct doses, the correct temperature at it is stored, and good supervision of the person who is vaccinating the child. Think that every child is your own child, and all precautions you would like a doctor to take for your child, you need to take it. If there is a AEFI which happens, report it to the appropriate authority. Don't be afraid. And next part is, when you fill the form, fill it completely. And in an untoward event of death, don't panic. Just contact us at the state AEFI and the medical officers will be there to assist you as soon as possible. That is one part. And the second part is that keep record of that AEFI form, one form with you, so that in the event of an untoward effect and you need a verbal autopsy to be conducted, because PM sometimes they don't allow. So then that is something which every doctor should know, what is a verbal autopsy as far as AEFI is concerned. So I think it is a huge topic, but just a few glimpses of it, what we can do.
Thank you. Thank you, ma'am. That was definitely, thanks for guiding us for the AEFI reporting. Now moving on to the second topic. Pallor is one of the frequent causes for referral to a pediatrician, and there are different causes depending on the age, maybe the condition of the child. But a systematic approach may definitely narrow down our differential diagnosis. So to guide us, we do have a pediatric hemato-oncologist with us, Dr. Preeti Naik, who's an assistant professor at D.Y. Patil Medical College. So over to you, Dr. Preeti.
Unmute. Preeti, unmute.
Yeah, she's sharing, I think so, sir.
Preeti ma'am, you can unmute now. Kindly try.
Let's start.
Good evening, everyone. I'm Dr. Preeti Naik, working at D.Y. Patil Hospital, Kolhapur. First of all, I want to thank you, Maha-IAP whole team, for giving me this opportunity. Now, without wasting time, I will start with my presentation. My child is pale. So, 12-month-old female child brought by mother with complaint of loose motion and fever. On history-wise, she is absolutely normal, except on dietary history. She was on mixed feed for first 6 months. Bottle feeding was there, and the inadequate complementary feeding was started by mother. And on examination, she is pale, while no any other significant finding. So this is a typical scenario which we deal in our office practice routinely. The child is anemic. So what next? We know there are various causes of anemia depending on the decreased production of erythrocyte, increased destruction of erythrocyte, and the blood loss. But how to approach this patient? One should, for this, one should take a detailed history of the patient. Considering there are various parameters which should be seen in history, like age. We know nutritional anemia is very much common from 6 months to 3 years, as well as in the adolescent age group. Beta thalassemia, which is the presentation will be from 6 months to 2 years of age group. Other than age, there are various other parameters like gender, inheritance, consanguinity, community, then infestation, infections, history of drug intake, dietary history is also important. We know poor breastfeeding for first 6 months of life and improper time and quality of a weaning food will lead to nutritional anemia. Also, consumption of a goat's milk may point out towards the megaloblastic anemia. Along with that, many times mother will come with a history of a pica only. So this eating of non-nutritious substance, which may be in the form of geophagia, pagophagia. So this will point out towards your specific diagnosis like iron deficiency anemia. So history in detail should be asked. Along with the history, physical examination, thorough physical examination should be done, which will give clues to the cause of anemia, like hyperpigmentation, which point towards the Fanconi's anemia, megaloblastic anemia. Then jaundice will point out towards hemolytic anemia, petechiae, purpura. This will point out toward the involvement of other cell lines. So one should consider leukemia, HUAS, hemolytic phases, congenital hemolytic anemia, thumb anomalies like the triphalangeal thumb or absent thumb or bifid thumb. This will point towards the congenital hypoplastic anemia like Fanconi's anemia, Diamond-Blackfan syndrome, platinaechia, cholineechia, glossitis, history of angular stomatitis. This will point towards the nutritional anemia. Then lymphadenopathy will suggest leukemia or lymphoma. Hepatosplenomegaly may point out towards certain marrow infiltrative disorders or malignancy. So thorough physical examination along with the detailed history is very important. Then we will advise a CBC. In the CBC, not only the hemoglobin total count and the platelet count is important, but there are various other parameters like RBC indices and red cell distribution weight, which will point out towards the degree anisopoikilocytosis. Along with this, every time whenever you are asking the CBC, ask your pathologist to see peripheral smear examination of that patient. So this will point out toward the specific diagnosis. So depending on the MCV, anemia again divided into microcytic hypochromic anemia or macrocytic anemia or macrocytic anemia. So the causes will be different in various aspects. So in short, detailed history along with the physical examination and the basic CBC can point out towards a specific diagnosis. There are some red flag signs also, like sick looking child, if the child is having growth failure or hypertension with edema, which point towards renal disorder or hepatosplenomegaly and lymphadenopathy and abnormal blood count. This should not be ignored to rule out other causes of leukemia also. Now coming to iron deficiency anemia, this is the most common nutritional anemia present worldwide, and the cause we know inadequate intake of iron in the diet or blood loss. On the diagnosis, the CBC will suggestive of a microcytic hypochromic anemia with wide RDW, and specific investigation like iron studies will be, we can advise, which will suggest of low serum iron, low serum ferritin, and increased TIBC. On treatment, every time ferrous preparation is preferred over ferric iron preparation. Also, deworming of the child is done, and this ferrous preparation dose should be 3 to 6 mg per kg per day, single dose, which should be given on empty stomach. And on advice, one should advise iron-rich diet to that patient. So take-home message: every child should be examined for pallor. History and physical examination point clinching clues to establish a diagnosis. And the simple CBC along with the RBC indices with TS examination and the retic count, it will point towards a particular disease. Hence, this is a most important test in any case of anemia. Also, one should watch out for red flag signs and the rational approach would lead to a more accurate diagnosis with minimum investigation and cost. Thank you.
Thank you,
Very
Dr.
nice.
Preeti. Kudos to you that such an extensive topic you have just covered in 5 minutes. So that was really excellent. Kanikar ma'am, can you just tell us certain salient points like in a busy OPD when the child comes to us with pallor? So can you tell us a few important salient points to be looked out for?
Okay, so one thing you have to remember that a child who is looking pale, they can come to you as a primary presentation. Parents bring with my child is looking pale. So you get a history. And the second part is you accidentally detect it, and that is a part of your examination. So these two things, always ask the history that does your child look pale? And there are certain things like listlessness, irritability, which are things which we attribute की सगळीच मुलं अशीच असतात. असं नाहीये. In fact, irritability or crankiness may be the first thing of iron deficiency anemia. So always history, examination, however busy you are, just look at 2 or 3 places. One is the palmar creases and the other one is your mucous membranes. If they are pale, then the child is having pallor, and it can be from mild, moderate or severe variety. Now, being in a medical college, we usually see everything that is severe, but for you, you have to have a high suspicion of it. Like, like you suspected that every child is likely to have some deficiency. So if that is an issue, just examine the liver and the spleen and the lymph nodes. If they are there, that means you need to investigate them in more detail, that anemia. But otherwise, it is likely to be megaloblastic or nutritional anemia. For megaloblastic, you have some other signs like knuckle pigmentation. So if you very briefly screen the child from the head to the toe, you will get one answer, physical examination. And a very, very simple thing, what you have to remember, that the only emergency anemia which is there is because of acute blood loss. And that time you need to refer the patient primarily for the diagnosis, hemolysis or blood transfusion. For the rest of the anemias, don't go for blood transfusion. Make a diagnosis, try the medical management with medications, reassess the patient. And treating iron deficiency is not the end by giving a medication. You have to give nutritional advice to the mother. Also, some behavior change may be required from the toddler's side. And megaloblastic anemia is something you need to be very careful, because that has got a lot of implications of neurodevelopment in future. So just a plain physical examination, 2 or 3 diet history, breastfeeding history, etc., and a simple test like CBC and peripheral smear. And from there, you take it ahead as to which type of anemia it is. So I will think that is it from my side.
Thank you, ma'am. Thank you for your pearls of wisdom. Moving on to the next topic. डॉक्टर माझ्या मुलाचे पाय सतत दुखत असतात. मला वाटतं की हे आपल्या ओपीडी मध्ये एक 2-3 पेशंट तर रोजचे असतातच. Leg pains is our next topic. Is it just a benign problem or do we need to be vigilant? So I call upon Dr. Sanjay Joshi, sir. He is the professor and HOD of ACPM Medical College, Dhule. Over to you, sir.
Start.
Good evening. Mrs. Patil came to the OPD, as madam said, with her 5-year-old boy, saying that doctor हा दिवसभर खूप उड्या मारतो आणि संध्याकाळ झाली की सांगतो आई पाय दाबून दे. A very classical and typical symptom, soreness, aches and throbs in a child's legs, mostly involving thighs and calves, is a very common problem in children, affecting more than 30% of the pediatric population. And growing pain is one of the commonest cause of leg pains, with a peak incidence between 4 to 12 years. Now, if you see the causes can be classified into leg pain in a well-looking child and leg pain in ill-looking child. In a well-looking child, growing pains, restless leg syndrome, or fibromyalgia, and an ill-looking child, septic arthritis, cellulitis, gangrene, and malignancy are some of the causes. The causes can be grouped in another group like bones and skeletal causes. Like they can be classified into acute causes and chronic causes. Acute causes like muscle cramps and spasms, overuse trauma. This is very commonly seen when the mother says that "Kalach ha marathon मध्ये पडला शाळेमध्ये and now is getting muscle cramps." And then injuries, sport injuries like fractures, tendon injuries, then flat foot anomalies, and then chronic causes like juvenile inflammatory arthritis, polychondritis, and Osgood-Schlatter disease. Then there can be hematological causes like sickle cell anemia, leukemia, hemophilia, neurological causes like painful neuropathies, and then vascular causes like DVT, varicose veins, and HSP. Infection is a very important group in which viral myositis caused by chikungunya, dengue, influenza viruses, and enteroviruses is a common thing. And then bacterial infections like septic arthritis, dactylitis, and cellulitis can also give rise to leg pains. And then metabolic conditions like hypocalcemia, scurvy, vitamin D deficiency, and rickets can be other causes. Now there are some saline features from the history which will help us in coming to a proper diagnosis, like the duration of the leg pains, then whether they are recurrent, are they unilateral or bilateral, are there some precipitating factors, and then pain, whether the pain is more during day or night, because growing pains are classically seen during night, and if there is an associated symptoms like fever, bleeding, rash, etc., and whether they are relieved by simple supportive measures or not. The severity of the pain can be assessed by a scale called as Colorado Pain Scale into mild, moderate, and severe. The clinical signs can be grouped into there are no much obvious signs as seen in growing pains, or then obvious injuries like fractures or CLW, the sport injury, and then clinical signs like fever or joint pains or rash or ecchymotic patches or hepatosplenomegaly, deep tendon reflexes or hemarthrosis. So all these clinical points will help us to point to a particular diagnosis. Now, something about growing pains. Growing pains are classically described as benign nocturnal pains of childhood. They are self-limiting. Interestingly, the pain is not related to growth spurt or growth site. The pain is recurrent, bilateral in thighs and calves. It is more in the late in the evening and or night. The child's sleep may get disturbed, and the pain is relieved by simple things like massage and never present in the morning. So the concept is that there's something called a pain amplification syndrome. The child gets growing pain because the child has a lower pain threshold in correlation to any part of the body, and therefore these children are likely to get recurrent abdominal pain or recurrent headache even in the later age group. When we are making a diagnosis of growing pains, we must keep in mind 5 red flag signs. Are they unilateral involvement? Because growing pains are always bilateral. Is there an associated fever, anemia, purpura, rash, something like that? Or there are swollen joints, or associated splenomegaly or hepatosplenomegaly, or an absent tendon reflexes. So these are the red flag signs when we are making a diagnosis of growing pains. Growing pains is the clinical diagnosis. No much investigations are needed unless the red flag signs are there, and then we need to investigate. Management is cause specific. For growing pains, it is conservative treatment. During pain, massage, just muscle stretching, local analgesics, physical therapy, and if needed, some NSAIDs. And preventive, you have to reassure the parents, even the child, and then parental education. Sleep hygiene is important, and then sometimes cognitive behavior therapy. So the take-home message is leg pain is a very common symptom in children. Growing pains is a clinical diagnosis seen in more than 20% of the children. Prognosis is very good. Red flag signs must be kept always in mind. Growing pains never seen during day, and joints are never involved. At the same time, when we make a diagnosis of growing pains, serious conditions should not be overlooked. Thank you.
Thank you, sir. That was a very simplified and a crystal clear take-home message by Dr. Joshi, sir. Kinikar ma'am, your take on this topic.
One has to remember that leg pains are very, very common. But what type of leg pains are is a challenge for a doctor. And what you need to keep in mind is, if you remember when you should in-depth analyze a leg pain, are certain factors like growing pains are very common. But when is a growing pain not so benign? is when you are having the cramps or the calf pain that is lasting for more than 12 hours, that means something is wrong. Or if the child has got swollen joints, it is not a leg pain that is benign. Whenever you have got fever associated with these leg pains, it may be unilateral or bilateral, think twice before you label it as a growing pain. If a child says, I am not able to move my legs at all, and there is numbness, and if this numbness is lasting for more than 1 hour, you need to make sure you have investigated the child properly. There are a few other things, like if with the leg pain, the child is not a happy child, looking like a sick child, and there are movements of the leg and the joints which are painful. So in other words, what Dr. Joshi sir has said, that there are red flag signs. So rule out all these things are absent. And then of course comes a major part is that you should not miss very critical and serious conditions like leukemia. There are certain malignancies which are there, but they are very rare. But at the back of your mind, rule out that the red flags are absent, and then you can label it as a growing pain, advise and follow up the patient. Don't leave them, because then if the pain continues, they will leave you and go to another doctor and another. And by the time they reach a higher center, it's too late as far as the serious causes of leg pains are concerned. Always look for a limp, how the child walks into your clinic. If there is leg pain with a limp, it is not normal. Okay, so you need to examine properly. All leg pains need not have x-rays. All leg pains need not be referred directly to an orthopedic surgeon. Physician is the best person for leg pains of a child. You can discuss with the others, but take the credit of diagnosing to yourself. And there is a lot to talk of leg pains. We can have a whole session, but I want to tell you all three of them, my colleagues, they have done an excellent job in 5 minutes. They didn't leave anything for me to be added. So I think this is a great idea. And I once again thank the entire team, two dynamic ladies, Dr. Renu and Dr. Deepa, and the entire team for starting such an innovative project, and my best wishes for the rest of the programs. Thank you.
Thank you, ma'am. So yes, leg pains should always be a diagnosis of exclusion, and we need to be aware of the red flag signs. So thank you, ma'am. And now for the further proceedings, I hand over the mic to Dr. Renu, ma'am.
Yeah. Thank you so much. The first three speakers have done very nice. Subbu sir, are you there? Please keep your video on, sir. Now it is your turn for rapid fire.
Sir, there.
Nice, sir is there. I think we will take at the end, I think so.
Yes.
So the next three speakers are there again. So we have total 6 speakers. 3 have done their job. Now comes Dr. Shirodkar, ma'am, Amruta Shirodkar. She is a senior pediatric consultant, Nanavati Max Super Speciality Hospital, Mumbai. And her topic is constipation. Constipation म्हणलं की बस आपले जे पालक आहेत ते एका डॉक्टरकडनं दुसरीकडे तिसरीकडनं चौथीकडे आणि कोणीही डॉक्टरनी आधी पहिलं सांगून द्यायला पाहिजे बाबा रे तुझं 2 वर्ष काही कॉन्स्टिपेशन काही सुधारणार नाहीये तरच ते आई आणि वडील नॉर्मली राहतात नाही तर ते इमोशनली कॉन्स्टिपेटेड होतात. आणि आता ह्याच्यासाठी प्रकाश टाकण्यासाठी येणार आहे डॉक्टर अमृता शिरोडकर मॅडम. Ma'am, please start your presentation.
Yes, thank you so much. I'll just share my screen. So thank you, Dr. Renu, and thank you all the members of the Women's Wing of the Maha IAP for this opportunity. A very good evening to all seniors, teachers, colleagues, and my dear friends. So constipation, we all know, is nothing but difficulty or reduced in the frequency of defecation. Frequency and the type of stools has to be compared with the normal patterns which are expected for the child's age and stage of maturation. 95% of the constipation which we see in our clinics is functional, 5% is organic. So what is functional constipation? It presents mainly at 3 periods in a child's life. after introduction of cereals and solid food in the diet, during the period of toilet training, and during the start of school. So we should remember a certain physiological causes like infant on formula milk or cow's milk, low dietary fiber, inadequate fluid intake, immobility, and starvation. Now, organic constipation, though constituting only 5%, we should always be alert. Look for a few common causes like Hirschsprung's disease, hypothyroidism, neural tube defects, anorectal malformations, vitamin D intoxication, celiac disease, and certain medications which we commonly prescribe in our OPDs like antitussives, antispasmodics. All these are known to constipate. So now, when do I suspect an organic cause? If there's a history of delayed passage of meconium after 48 hours of life, if the constipation presents right from birth or early infancy, especially if the child is on exclusive breastfeeding, if the child is passing ribbon stools, which are very narrow, if there is associated urinary or bladder incontinence, if there is weight loss or poor weight gain, if there is any history of delayed growth, any extraintestinal symptoms, any risk factor for Hirschsprung's like a child with trisomy, or any severe abdominal distension. So if all these are present, we should suspect we might be dealing with an organic cause. Now, when do I suspect a functional constipation? So onset coinciding with the 3 major periods, as I already said. Any faulty diet, ask or dietary history, very important. Ask for bread, biscuits, noodles, pasta, pizza, or excessive milk in the diet. Any history of retentive posturing, any presence of large fecal mass in the rectum, history of painful bowel movements. Sometimes these children pass very large diameter stools which can obstruct the toilet. An episode of incontinence, especially if after the child is toilet trained, and good response to conventional laxatives supports the diagnosis of a functional constipation. Now, moving on to examination, when I'm examining the child, I should look at the growth, look at abdominal distension, any masses, any fecal masses. Always do a thorough neuro with a sensory motor examination, abnormal muscle tone, and look for DTRs. Look for the patulous anus, look for an absent cremastic reflex if it is there, and do a per-rectal, not always indicated, but yes, in a few cases when we are suspecting organic, we should do it. How do I investigate organic constipation? So yeah, there are a few imaging and lab tests. You can do an X-ray abdomen or USG abdomen. In selected cases, we might need contrast studies and barium enema. We may do an X-ray spine if we are suspecting NTDs, and a biopsy may or may not be required as per the indications. Lab tests, of course, we send a TSH, a urine analysis, a celiac screen, electrolytes, and calcium. Do I investigate a child with functional constipation? The answer is no. The diagnosis is clinical, but a plain extra abdomen sometimes can demonstrate the loaded colon, and sometimes we may need supportive investigations if we are having any nutritional issues. Treatment, most importantly, parental education. Second is bowel retraining, which involves 4 main steps: disimpaction, prolonged laxative treatment, dietary changes, and gradual tapering and withdrawal of laxatives. Parental education best explained with the help of a proper diagram where we can actually show the parents that why the child is constipated. There is a huge fecal mass in the rectum and the nerves are stretched out and the muscle does not work well. There is a buildup of hard stool and the liquid stool passes around the hard stool and presents as fecal soiling. So the importance here of prolonged treatment, consistent emptying of the colon for months, maybe with laxatives and toilet sitting, so that the nerves and the muscle gain their control again and they work well. So this needs to be explained well. This is followed by disimpaction. Of course, the first line of therapy we all know is polyethylene glycol. We can also use lactulose or lactilol. Rectal medications can act rapidly, but they are invasive. They can, in fact, have, the child may be get fearful to have it, so preferably avoided. After disimpaction comes the therapy of maintenance regimen, where we need to retrain the bowel and avoid reimpaction. So here we need to give the laxative in adequate doses. So we maintain a pattern of soft bowel movements once or twice a day. Polyethylene glycol is again preferred. We can also use other agents. Adjuncts are obviously behavioral modification. The child must be told to sit on the toilet 5 to 10 minutes after meals, regular habit to be made, a stool diary to be maintained by the parents. Reward system. Remember, reward is for sitting on the toilet and also for not soiling. Reward is not for passing the stool. This needs to be explained. Dietary modification, we try and increase the fiber intake, increase the fluid intake, eliminate cow's milk if you feel it is excessive, and probiotics also might have a role. First, we need to follow up the patient weekly, then fortnightly, and then monthly till normal stooling. Always ask for the stool diary. Gradually reduce the laxatives, don't need to stop abruptly. 50% of the children do recover, 30 to 40% may need prolonged treatment, and 10% are still intractable. So we revised here, just cover up in less than a minute. 95% of the childhood constipation is functional. Functional constipation can be diagnosed clinically. Red flags to be always, we should be on high alert for organic. Parental education and bowel retraining are the mainstays of treatment. Appropriate diet has to be given. PEG is the laxative of choice. Prolonged treatment necessary, and it can go on for months. And functional constipation can be prevented by anticipatory guidance about toilet training and diet. Thank you.
Dr. Renu, please unmute yourself.
Yeah, thank you, Dr. Amruta. You have done a very great job for a very long topic, which is a chronically constipated child. So, Dr. Nani Vadikar, sir, I would like to have some comments by you or ask question if you require to Dr. Amruta.
First of all, thanks MahaAP and thanks MahaAP Women's Wing for having given me this opportunity to talk. Dr. Amruta has done an excellent job. She has covered the entire topic in 5 minutes very well, and she has covered it very nicely. I don't want to add anything but a couple of things which are absolutely from the ground level. Gone are the days when we were treating more of diarrhea and less of constipation. Now, in fact, the treatment of constipated child is more common as compared to diarrhea, maybe in a private setting. In a government hospital, maybe diarrhea will be still more, but we are seeing more constipation children as compared to the diarrhea patients. Second thing is, whenever we see a child who has come with a history of constipation, as she has already put in, we know that the red flag signs are there or not there, and we know that it's the functional constipation which are going to constitute for 95% of the patients. So there, the first thing which comes to my mind as a pediatrician is I have to spend at least 25 to 30 minutes in the first visit, because that is where the patient is going to be convinced that whatever you are telling and is all scientific, and you explain why a child is getting constipated. Because there is always the tendency of the parents of denial that why my child's everything is fine, still is constipated. So we have to give them a clear-cut idea as to what dietary changes are needed. And second thing is, this is going to take hell of a time before the child comes back to normal. The other factor is that do not consider that the constipation is present only in the urban children. It is very much there in rural population also, what we in Kolhapur call typically as a milk biscuit syndrome, because the child is fed only with milk and biscuits. So that leads to constipation. And the last thing is the toilet training and the reinforcement by the parents. There, one more important thing which needs to be added is always ask for which kind of toilets the household has got, because majority of the households now have got the Western type of toilets, whereas Indian system is the best system. Now the West also has started accepting this fact. So this needs to be reinforced, that the child should be sitting in a natural Indian squatting position. The rest of the things she has already covered well. And what is important, again, carry your messages. Two important things. First, spend good time with the parents. And second is that tell them that this is going to be a chronic process. It's not going to stop in a couple of days or a couple of months. Thank you.
Thank you, sir. There is one question, Amruta, for you. Absent cremasteric reflex in constipated child, what does it denotes?
So yeah, so basically we have constipation associated with bladder bowel dysfunction as well. So we know the nervous supply of the bladder and the bowel is interconnected. So we always test for cremasteric reflex just to test for the nervous as a part of the nervous examination.
Okay, got it. Now to move to the next speaker, Dr. Kaustubh Deshmukh. His topic is headache, डोक्याला ताप. आता डॉक्टरांना खरंच डोक्याला त्रास आणि त्यांची सटकते जेव्हा त्या चाइल्डचं डोकं दुखणं कमी होत नाही, आणि ते फंक्शनल आहे का ऑर्गॅनिक आहे हे शोधण्याचंच बिचारा 5 वर्षाच्या आतल्या मुलाला जर का झालं तर काही खरं नाही. तर आपण आता जाणून घेऊया हेडेक बद्दल. Dr. Kaustubh Deshmukh is MBBS MD, fellow neonatologist from Amravati, working in Deshmukh Maternity and Children Hospital. Over to you, Dr. Deshmukh.
Thank you, madam.
Kaustubh, you'll have to share the PowerPoint portion.
Yes, sir. Yes.
The Firefox, it seems. You can stop sharing and then go to that specific screen of your PowerPoint presentation.
Network issue so
No problem. Pallavi madam, can you share
Yes,
yeah.
ma'am. I'll share.
Kaustubh, don't worry. You
Yes,
stop
ma'am.
sharing, Kaustubh.
Yes.
Pallavi will do it. Be calm. Don't have headache.
Yeah, thank you, madam. Yeah, very good. Good evening to all, respected madam and sir. My topic is today's headache. चला जाणून घेऊ हेडेक. मुलाची होते डोकेदुखी आणि आई वडिलांची आपल्याला होते डोकेदुखी. Next, please. Next slide. So headache is in children and adolescents is very common. A steady, alarming increase in incidents attributed to changing life habits. It's a neurological disorder, impacts not only the family, school, performance, social life, mental health, and quality of life. 75% complain by the age of 15. Migraine reports 3.9% in the age of 7 to 15 years. Common in boys. Adolescent girls had high prevalence. Next, please. So coming to etiopathogenesis, headaches in children is primary, which is intrinsic to nervous system, such as migraine and tension type headache. That should be remembered first off. And secondary, it should be associated with an etiology. For example, viral illness, sinusitis, post-trauma, space-occupying lesion, encephalitis, meningitis, brain tumor, sinus vein thrombosis, ischemic stroke, intracranial cyst rupture, VP shunt malfunction. Acute chronic progressive headache occurs generally due to secondary causes. As I mentioned in the secondary causes, the example, and always present in the OPD setup as emergency. And life-threatening cause of acute and chronic should be remembered is raised intracranial tension. Next, please. So clinically, pediatric headache is challenging and children have limitations. An orderly approach should be kept, that proper diagnostics, thorough history, general neurological, psychological evaluation, lab testing, and neuroimaging scans, especially in secondary causes of headaches like space-occupying lesions, stroke, tumors, intracranial hemorrhage, and trauma. Keep an headache diary, example displaying character, symptoms, and trigger factors, especially if a child coming to OPD coming with a primary headache like migraine. Next, please. So coming to red flag signs, headache history is very crucial, while possibility of secondary are first ever in the life, in say recent onset, increase or frequency. It should be associated with an hospital location, awaking from the sleep with severe vomiting or associated with straining. These are the all factors coming to secondary, which I mentioned in the last slide, that secondary causes of headache. Primary is always remembered, it should be a migraine and tension type headache. So what are the questions should be remembered? When and how? कधी डोकं दुखलं, पॅटर्न कसा होता, फ्रिक्वेन्सी कशी वाढत गेली, टिपिकली कधी थांबलं, किती वेळ लागला थांबायला, इट्स अन ऑरा और प्रोड्रम, कोणी प्रोहोगेट केलं का की एकदम डोकं दुखायला लागलं, इट्स असोसिएटेड विथ पेन अँड सिम्पटम्स, आर देर इज अन हेल्थ इश्यूज or any medicines taken during the or, and foremost is the family history. Now I am seeing so many patients coming with headache, which is primary is migraine, but family history and family problem is a very diagnostic importance in today's era. Next. So headache diagnosis, one should keep that examination includes cervical spine, vascular evaluation of the skull roots, temporomandibular joint, nerves including supraorbital nerves, occipital nerves, eyes, sinusitis and teeth. Eyes, most of the time, that diminution of vision. I have seen so many patients, headache, doku dukte, disat nahi, मागच्या बेंचवर बसतो, काय करू, आई म्हणते अभ्यास करत नाही. कॉमनेस्ट आहे. सो विथ रेफरन्स टू ऍज अ पेडियाट्रिशियन वी शुड टेक अ सेकंड ओपिनियन. एकदा डोळ्याच्या डॉक्टरला दाखवून तसंही दिसतंय, तसंही अभ्यास करतच नाही. सायकोलॉजिकल व्हेरी इमेन्स इम्पॉर्टन्स इन ए करंट एरा. स्केल्स ऑफ डिप्रेशन, अँझायटी अँड फॅमिली इंटरव्ह्यू. घरी भांडणं होऊन राहिले का? कधी कधी आपण कोणी विचारलं तर सांगत नाही, पण मुलांसमोर इतके भांडणं होतात, आई वडिलांचे बाजूला होतात, कॉरल होतात, त्याच्यामुळे पण एक गोष्ट लक्षात ठेवावी वाटते. नेक्स्ट. So migraine, tension, headaches are primary. That trigger should be remember. Headache diary should be maintained in migraine. Modification of lifestyles and behavioral therapies. Migraine, that's rescue management, dark room, application of cold in forehead. Medicines like ibuprofen, acetaminophen can work. Children more than 12 years, nasal stomach can use. Frequent headache, prophylactic medications. Next, please. So key message is that pediatric headaches are common. Secondary usually present in emergency setup that I have mentioned some example. Majority of recurrent are primary in the nature. Appropriate identification of headache history and headache diary should be analysis helps a lot. Behavioral therapy along pharmacological management used to reduce social absenteeism, disability, improve quality of life, and in recent advances highlight presence of amblophobia is in evaluation and use of headache drawing is great as a diagnostic aspect coming in new era. Thank you so much.
Thank you, Dr. Kaustubh. Excellent slides you have put up in a very short time for the headache. Dr. Nani Wadekar, sir, I would like to express your views on this, or whether you would like to ask him question.
Yeah, Kaustubh, it was a very good presentation.
Thank you, sir.
How many times do you see ophthalmic problems as the reason for headache?
Sir, so many, almost 90% in the pediatric population, that's in the school age group children, sir. Those who are attending the schools and those who are backbenchers sitting and reflectively changing their position in the school, sir.
Yeah, second thing is when we talk, you have correctly said, we have to take a good history. Basically, yes, whether it is episodic headache, whether this headache which is coming up gradually increasing, because that will tell us whether we are dealing with a migraine or a tension type of headaches, or whether we are dealing with some sinister condition like intracranial tension, etc. Nowadays, there is another entity where we see that a lot of teenagers do late night, they continue to watch the screen for the late night till the late night, and there is a binge watching, etc. And that affects their sleep quality also. So that also is going to interfere in their daily activities, which will also add up and which will come as headache. So that needs to be seen as an important part. Rest, if everything is fine, the presentation was very good. Thank you.
Thank you, sir.
Yeah, thank you, Dr. Nani Wadekar. Thank you, Dr. Kaustubh. Now is the last topic by Dr. Girish Cho. The topic is fever with rash. It is quite very huge topic, but for 5 minutes, we will see how he presents. So, sir is a professor, Department of Pediatrics. He is at Krishna Institute of Medical Sciences, Karad. Sir, over to you.
Should I start?
Yeah, go in the slideshow mode, sir.
Yeah. I have shared my...
Yes, sir, we can see your slides.
Yeah, now we can see it. Yes, you can start, sir.
Okay. Good evening, everyone. Fever with rash is a very common problem caused by infections and non-infectious disorders. We usually group these disorders of fever with rash depending upon what type of rash it is. It could be a papule macule. We begin with maculopapular rashes with fever. Imagine a child with fever and viral prodrome. There is an anthem of Koplik spots, and next day the rash appears on the hairline and behind ears. Next day the rash spreads caudally. Yes, you are right. This is measles. The differential is rubella, where there is a mild prodrome and a lymphadenopathy, which is posterior auricular as well as cervical. Another differential is there is a marginatum with its typical slapped cheek disorders where you get fever with maculopapular rash or exanthebrium, where the child is small one, the fever disappears and then the rash appears and face is spared. Infectious mononucleosis occurs in older children, and there are lymphadenopathy as well as fever, sore throat symptom complexes along with mononucleosis. Drug rashes are typically seen with target lesions, and there is severe itching. Dengue fever is another condition where you get initial flushing, pruritus, followed by islets of white in the sea of red type of rash. The rash centrifugally spreads and later on may become purpuric. Systemic lupus erythematosus is associated with photosensitive rash, which is spread in a butterfly manner over the cheeks and nose. Juvenile rheumatoid arthritis is associated with a transient or evanescent rash, which appears only at the height of fever. Peripherally, these lesions, if maculopapular lesions are seen, consider 4 different conditions: erythema multiforme, symmetrical lesions, and target. Hands, foot, mouth disease, where we get initially maculopapular tender lesions, which change into vesiculobulous lesions and affect palms, soles, and buccal cavity. Secondary syphilis, which is uncommon, but can cause dark stained maculopapular rashes. And lastly, not to miss, bacterial endocarditis with necrotic lesions, Janway lesions, ocellular nodes, heart murmur, and microscopic hematuria. Next group is desquamating rashes. We should not miss complete or incomplete Kawasaki syndrome. And the differential diagnosis for Kawasaki would be scarlet fever with strawberry tongue, with pastia lines, with erythroderma, and typical sandpaper rash. Another differential is staphylococcal skin syndrome occurring in a smaller child with blisters, tender skin, and denudation and Nikolsky sign positive. We should not miss here COVID-19 rashes, which can also desquamate. Next group which desquamates is toxic shock syndrome due to staphylococci and streptococci, where there are high-grade fever, erythematous lesions associated with multi-system involvement and shock. Stevens-Johnson syndrome also begins with erythematous macules, develop into necrosis and vesiculobulous lesions, and associated with 2 or more mucosal involvement. Not to forget that vasculitis can also produce rashes with fever. Urticarial rashes are also seen, which do not itch but burn. And erythema nodosum is painful nodules or shin seen in many conditions. Next group is of vesicular lesions, which are typically in chickenpox. Polymorphous is pathognomonic of chickenpox. All stages of the rash are present at the same time. Small discrete lesions are seen in herpes simplex and herpes zoster. There are dermatomal involvement. Not to forget purpuric rashes because of the 3 sinister conditions associated. Acute meningococcemia, where the child is brought with shock and extensive hemorrhages with or without signs of meningitis and DIC. Dengue hemorrhagic fever, the child becomes afebrile and goes into cold shock followed by hemorrhages. Now, rickettsial infections need high index of suspicion. Indian spotted fever will present with maculopapular rashes and involvement of palms and soles with petechial lesions. In scrub typhus, you may find Eschar. Thus, totally, we should have a high index of suspicion depending upon the characteristics of fever, characteristics of rash, sequence of the rash with fever, type of rash, mucosal involvement, itching, depending upon the past history of travel, bite, immunological status of the child, treatment that was given, vaccination record of the child. The red flag signs are progressively lethargic child, erythematous, necrotic, or purpuric rashes, palpable purpura, painful purpura, high-grade fever continues in spite of the disappearance of the rash, multi-system involvement, shock, and photosensitivity. Investigations depend upon what we are suspecting. Occasionally, skin biopsy is needed to diagnose vasculitis and drug-induced rashes. Treatment is symptomatic for fever and itching and specific depending upon the cause. Thank you very much for your patient listening.
Yeah, thank you so much, Jog sir. You have completed your all the presentation of rash in so much less time. And over to you, Dr. Naniwadikar, sir, for your expert comments.
Yeah, thank you. And congratulations, Dr. Jog, sir, because fever with rash is a huge topic. Maybe a whole day would go in this, but he has covered it and covered it nicely. A couple of observations. One is that again, a good history, and whenever the child comes with fever, as a treating pediatrician, our first aim is till the time we do not see the focus of the fever, it is preferable just to keep on giving the antipyretics to the child, because majority of the times it so happens that either the viral illness or viral exanthem will surface over a period of time where you are sure that what you have treated from the initial part as a viral fever and the exanthem has come subsequently. We have all know that in a season of dengue, when the patient comes with fever with headache and retroorbital pain, we know that probably something is coming up, and maybe after third, fourth day, the patient starts showing rash. So we are sure that we have not gone wrong in not starting an antibiotic, because in this era where what is important is we have to use our antibiotics wisely. So any child who comes with fever with no localization, let us not rush, because over a period of time, the things are going to get evolved. Of course, things like meningococcemia, which are rare, but if one picks up that in early time, then we have to treat the child immediately. The rest of the times, as Dr. Jog has put in, the way the rash has come, the way the rash develops, and the way the rash is distributed, we are able to make the diagnosis of the condition appropriately, and then use the investigations only when needed just to support our diagnosis. So that gives a patient a good benefit that a good clinical history and examination has given a proper diagnosis so that the treatment is done properly. That's all. Thanks.
Okay, thank you, sir. Thank you so much. Now, over to Dr. Subramaniam, sir. Sir, can you unmute yourself?
Yeah, thank you, Renu. And
Sir, now we require a rapid fire round from you to our 6 participants. Can I ask Dr. Prachi to unmute and start the video? Her topic was AEFI.
Prachi, I wanted to just know you what is the most important problem for a pediatrician during adverse event following immunization? How a pediatrician should handle it. Yeah, that's the challenge.
If it's a serious adverse effect.
No, I will give an example. I gave DPT to a healthy, smiling child walking to your OPD, and after injection, his head is down. What will you do?
Then we need to rapidly assess the child for the pulse and the respiration and give adrenaline injection depending on the age and the weight of the child.
You will calculate the age and weight of the child?
I would have been taking the patient details before giving the DPT vaccination. So I would have a rough idea at least.
I think I can see smile on the face of Dr. Devraj Raichur, who is my mentor. What happens, let me tell you, beta, what is happening to all of us whenever we are given topic in T20 or short presentation is that we read the topic. Please don't read the topic because you are biased. Please understand adverse event following immunization. Have you come across in your life? Let's say you have practiced for 20 years, 30 years, or sometimes 15 years, 5 years. You can tell that in my 5 years, I have not seen even a single case. No problem. That's your experience. You have every right, and everything need not be in the textbooks. All right. That is one. In my life, I have seen one event. So that means a lot to the practicing pediatrician. He gets a message. Okay, this is such a rare event. Do you accept, beta? Do you agree on this point?
Yes, sir.
Yeah, that's first thing. Second thing is, none of your textbook, Nelson, Wilson, nobody comes to your help when there is an adverse event. Please remember, it's a reflex.
True.
So preparedness is the answer. You should have told me that I will always have an adrenaline syringe ready, irrespective of the age, weight. I'll push that half cc or 1 cc no matter what happens. Okay. Do not worry about adrenaline, worry about the event. Maybe that could have been the answer. I mean, how a pediatrician should prepare is that he should have it ready Anticipation is the key, not thinking of anything else after that. I think that's the point. So in all our refrigerators, there should be a syringe of adrenaline filled along with the immunization. That could have been the simple message. Third, what is the, let me be very brief. Renu, you can cut me down also if you want. Now, the third thing important for us is, it is not adverse reaction following immunization, which is the perception of the pediatrician. It is adverse event following the immunization. Event could be anything related or unrelated to the administration or the drug. So this is important. A girl faints after an injection, may be vaccine, may not be vaccine, but the fainting is because of vasovagal or teenage behavior, and therefore that becomes an event and it will be reported, and there won't be any cause and effect relationship between them. So every time, in why we have got reporting of adverse events, not adverse reaction following immunization, is because we want a bigger basket to catch more fish.
True, sir.
This is the message that we want from adverse event following immunization. Lot of us say, don't worry, it's like, but we always worry. Please remember that and accept it. We are worried. We will underreport. We will not report minor ones. We will report only adverse reactions. We are more worried about parents than about our district immunization officer or anybody else and a child. Do you all agree on this point? Let us be very confessing when it is 5 minutes talk. So these are messages from me. Let me go to the second one, which was on leg
My
pains.
child is pale.
Pale, okay.
Dr. Preeti.
Dr. Preeti. Dr. Preeti, I wanted to ask you, if a child looks pale, is it more likely to be nutritional or non-nutritional? I'm just asking a question from you, from your experience.
Sir,
Just
if we see our scenario, nutritional will be the most common cause, but that will depend on many factors also, sir. Like the age
unmute yourself now.
of presentation, then other factors like physical findings. That will depend on that.
Okay. The second challenge as a hematologist you could have addressed is how to recognize pallor in otherwise dark children or dark persons like me.
Sir, I think we have to see the
I may
palmar
be asking
crease.
some foolish questions, but they mean a lot to the practicing pediatricians.
Yes, sir. Sir, we have to compare patient's palmar crease with our palmar crease. Of course, the hemoglobin of the examiner should be good for that. So if it is more dark.
Okay, that's a good idea. And you would ask them to show and all that you will do. I think when in your talk, you could have even covered with some pictures as to how, rather than the flow diagrams and all, what a pediatrician should look quickly. See what is the idea of this 5 minutes presentation is for the practitioners to remember quickly what I should look from head to toe. And that's enough for, something about at what hemoglobin level you think pallor appears. I mean, I don't know the answer. I respect you as a hematologist, which I don't know. I wanted to know from this session at what hemoglobin level the pallor appears.
Pallor appears means on physical examination.
Yeah. It's just a Google from me. Even I am confessing I don't know the answer.
In my point of view, if the child is having 9 to 10, 8 to 10, so it is very difficult to see clinically. But if the child is having less than 7 hemoglobin, then we can definitely diagnose pallor on physical examination.
Excellent point, Preeti. I asked you this question. I was knowing the answer, but I pretended that I didn't know. But I will tell you why. It only means that in your entire talk, you should have told that there can be anemia without pallor. That's all is the message. So therefore, can we go with a message that every Indian child would require iron until proved otherwise? That could have been deworming. So you see, you have to scale down from an hematologist perspective to a general pediatrician and what he should do from tomorrow. Can all of us take an oath that we will universally deworm everyone and probably think of either treating or prophylactically supplementing iron for every other child? This is something that can be simple message, but yet make huge difference in our practice. Correct? Yeah.
Okay, sir. Thank you, sir.
No. Fantastic points. And I enjoyed your entire presentation, right? Okay. Now, the next one, Renu.
Yeah, Dr. Sanjay Joshi, sir, leg pain.
Sanjay Joshi, sir, you are head of the department, and we have a lot of regards for you. We have met on many platforms. Congratulations to you. And on the leg pains, what I wanted to know is when you can say a leg pain is benign, or is it really leg pain, or is it not a leg pain? Unmute yourself, sir.
The first thing is when the mother actually, as I told you, mother brings the child to you with the complaints of severe pains. And the 3-4 important points are there, that the pains are specifically in the evening or night. They are not present in the day. It is classically said that if the pain in the morning, if the child complains of pain, that is early in the morning, after morning, then it is not leg pain. So leg pain definitely disappears in the morning. The child playing everything fine, and in the evening again the child complains of pain in the that's the first thing. Another thing is it is always bilateral. Third thing is there are no associated things like no joint pains and no other systemic symptoms.
Fine. For want of time, I'll cut it for you. Why it is called growing pain?
Sir, actually, there is no correlation between growth spurt or growing.
I think that point you could have brought it out. See, like
actually, I brought it.
yeah, fantastic. Okay, maybe if just. I'm sorry if I missed that point. Maybe if I miss it, means that you could have stressed it more. Okay, fine. So that 2 minutes should be so important. It's fantastic. If you give paracetamol or ibuprofen or something and it doesn't respond, what a pediatrician should do for growing pain? I gave a couple of tablets and still it's persisting.
So if history and clinical examination reveals that there are no positive red flag signs and no other things, and if it is not responding, you have to just counsel the parents and tell them that the pain will disappear. It will take some time. You can just continue paracetamol, some local analgesics. These are the only thing. But
okay, the next
line points in the history and clinical examination is very important.
Fantastic. Now the next question I wanted to know quickly from you is, do you think that the pediatrician should prescribe vitamin D to all the children with leg pains? This is a very common thing that floats in the minds of pediatrician. No, because if you do vitamin D levels, it will definitely come low. So therefore, I wanted to know from you what a pediatrician should do. I do agree. I think Sonali is also nodding the head. She also wants to know whether tomorrow she should prescribe vitamin D to all of them.
So ideally not, sir.
Okay, done. So if you can give vitamin D for vitamin D deficiency, not for leg pains, that's your answer? Yeah, fantastic. Okay. Thank you so much, Sanjay. The next topic is on headache. Headache by Dr. Kaustubh. Yeah, Kaustubh, Deshmukh, your presentation was fantastic. You told between primary, secondary, and everything fine.
Yes.
Now, all that I wanted to know is, how do you recognize that primary? Is it exclusion of secondary, or is it that straight away you diagnose primary? That's exactly what a pediatrician wants to know.
No, actually,
primary a diagnosis of exclusion of secondary, or is primary a diagnosis by itself?
According to patient condition and patient bring out to OPD, that as a secondary headache, that is the specific etiology, that the thorough history should be very important, sir, because primary headache should be only a migraine headache and the tension type headache. But secondary has some etiology and the cause that there is, and the patient presenting with other error, like it's very drowsy, coming with long history of fever. In case of meningitis, there is some on examination, there is crackpot's sign is positive.
Agreed. Deshmukh, you are getting too much into the subject. Okay, let me cut it for you. And on a lighter note, Deshmukh, I'm going to ask you one question.
Yes, sir.
How many minutes of interview you are taking for a child with headache before you prepare the topic and after you have prepared the topic? Now that means to say how many questions you are asking to a mother with a child coming to your headache. Be honest, 2 or 3 months back. And how many questions you were asking a couple of days back to a mother who is walking with a child with headache?
Sir, I used to give 15 minutes to the OPD and I almost asked 10 questions to the mother, which frequently come to my OPD in 2-3 visits with headache. In primary visit, I just notify the what type of headache it is. It's an associated with frontal headache, most common in the sinusitis. Second, the era which is going on.
Agreed. No, don't go there. I was just wanted to know, is your questions increased after the reading or is it same?
No, putting the questions almost, it gives me some era to judge myself what type of headaches I am going to begin with and what counseling should I done with the patient.
Okay, do you think that couple of things like what a pediatrician is not doing but can be done, are we seeing the fundus examination? And the second thing that a pediatrician wants to know is, should he refer to an ophthalmologist, a ENT surgeon and a neurologist?
No, sir.
And should he do a CT scan? I think these 4 answers they want from you. First question is, when will you refer them to an ophthalmologist?
No, sir. Initially, pediatrician should do the fundus examination into day-to-day practice.
No, forget fundus, sir. Refractory errors. This is a common question.
Yeah, as the history suggests, as my OPD is almost what everyone OPD is according to, I sit the patient and I'd tell him to see the alphabets which are bigger.
Okay, you
and
mean
smaller.
to say you ask him for history oriented rather than referring them to an ophthalmologist?
Yes,
ENT?
ENT, most of the patient come to us OPD, sir, with a cold, cough and fever. This is the grade. And so according to headache, I just ask them what is the stuffy nose is there, or it's a frontal type of headache which leads to sinusitis, or sometimes it may be temporomandibular joint also. And also there is a commonest cause I've seen in pediatric OPD, there is a fall of children during playing, when there is a 1-year child, mother is taking the child and suddenly drop the child. They came to so much time in the OPD.
Last question is, when will you do CT scan? 1 second, let me complete the question. And in a mother, and there are no clues of any danger signs or ICP, neurological, etc. There's nothing. Only headache is there. Will you or will you not do CT scan, MRI?
No, I will not do CT and MRI unless and there is an there is an CNS symptoms and
okay, so migraine type of headache, will you do an MRI to rule out anything and then start treatment?
No, if the headache diary and the patient is treatment going on regularly on the pharmacological basis, but there is no need to go for an MRI and CT for every headache unless and until there is a secondary cause associated and the history.
So your message is, for secondary I will do MRI, for primary I won't do MRI.
No, secondary, any patient came with the emergency to the OPD with a secondary headache with an associated pathology, that should be go for an MRI and CT. Primary should not do unless and until there is a regression factor and there is.
Okay, last question. Would you give paracetamol or ibuprofen?
Paracetamol.
What is the dose? Is it same dose as fever, or is it a different dose for headache?
No, it is the same dose, 15 mg per kg body weight.
So I think even though my questions look simple, this is what a pediatrician wants to know, rather than, the classifications and so on and so forth. I mean, fantastic presentation, Deshmukh. We are proud of you. Okay. So fantastic.
Sir, Dr. Gawane has asked whether blood pressure is being taken in every child of headache.
Yeah, it should be taken in the regular pediatric OPD, but I have initially mentioned that the children more than 15 years, between the 7 to 15 years of age, should be blood pressure should be taken in the regular basis. And if there is a history of a child presenting with a congenital heart disease initially diagnosed in the childhood, that we used to go for blood pressure regularly.
Okay. Dr. Sulva has asked, headache never occurs due to refractory errors like that we learn in ophthalmology classes. So is it true?
No, most of the refractive errors is the most common condition we enclose in the routine OPD practices. But occipital headaches are most common associated with the refractive errors in the more school-going children, more than in 10 to 15 years of the age.
Kaustubh, I wanted to just ask you a quick fire. I will show the gestures of the child and you tell me the cause of the headache.
Yes, sir.
You know, like this. This is tension headache.
No, it's a temporomandibular headache.
This one.
So I'm not seeing it.
Okay, I'll just remove my specs. Fatigue.
No, sir, I'm not getting video. Not
Retrobulbar fatigue.
Image is not.
Image is not coming correct. Okay, sorry. Then what about this one?
Sir, actually, आप दिख नहीं रहे sir मुझे.
Oh my God. Okay, now can you see? Okay, now.
No, sir. No, sir.
Hanging.
असा करतायत ते.
Madam,
I'm only audible to you. Okay.
Yeah, sir. Now it's sensing. Yes, sir.
Okay, now this one.
Throbbing headache.
Throbbing headache. This one.
Sir, image is not. Again, you.
असं करतायत सर असं करतायत.
Okay.
Migraine headache.
Migraine headache. Okay, fine. I mean, I'm just trying to tell you that these are the simple things that would add value to your presentation. And fantastic things from you, Kaustubh. Beautiful. Fine. Let's go to the next one.
Dr. Amruta Shirodkar, constipation.
Amruta, congratulations to you for constipation. Okay, that was a fantastic, very thorough classical presentation. Amruta, I wanted to know.
Yes, sir.
What two things which I wanted to just add to your presentation, which I will be asking in the form of a question.
Yes, sir.
Would you like to examine a child with constipation? And if so, what is that you want to examine as far as the external, anal examination is considered?
Okay, so yeah, thank you, sir. Sir, examination.
How will you motivate that child who is reluctant for examination in constipation? Do you agree? Yeah.
Okay, so if we have any red flags on history, like I already discussed in my presentation, we would obviously definitely like to go ahead with a rectal as well as a rectal examination. PR examination per rectal, children generally don't allow. It is very difficult to do it. But yes, we should do it if the signs and symptoms are especially present since infancy, or there are any extraintestinal manifestations, or if we are thinking suspecting constipation because of any other organic cause. So,
okay. No. I don't want you to present completely. I will cut it short. Suppose a child declines examination. What are the probabilities?
So you're saying the child is refusing the exam.
Pediatrician to motivate, or is there something in the child?
Sir, he could be having a painful anal fissure or something, so he's not allowing examination.
So that's simple, isn't it? So you will examine the child after treating you will give paracetamol and then examine?
Yes, sir. And okay, also ask him, give some local painkiller, ask for a seeds bath, wait for the fissure to heal, and then maybe examine the child.
Okay, fine. That's one point. And when you open and examine, I will give you two scenarios. One where the sphincter is very tight, and the second one where the sphincter looks apparently normal. What are the possibilities? I think this is simple, isn't it? If the sphincter is tight, then probability of a fissure is quite high. Yes. And suppose if it is normal patulous, I don't know how to describe. I think it is relaxed.
It is
in that case, the probability of the other causes should be thought of, including neurological. Agreed?
Yes, sir.
Fine. The next question which I wanted to know is, do you think how the child passes stools, in what posture, does it matter?
Yes, it does, sir, because in functional constipation, many a times we get retentive posturing. So child can cross the legs and holds the stool because there is fecal incontinence. The liquid stool is leaking besides the hard stool. So crossing the legs is very important. Also, if there is a Western toilet, we should ask for a comfortable position for the child. Many a times we also advise a footstool, so the angle between the rectum and the anus is maintained and the child is able to pass the stool comfortably. So again, that position becomes important. What kind of toilet they have at home, whether it's an Indian or a Western.
I think Amrita, if I could simplify for the pediatricians, keep the rectosigmoid vertical when passing stools. That could be a simple message, and I think everybody understands the rest of it.
Yes.
Whether the child squats, whether the child sits on a commode or whatever, your rectosigmoid should be made straight, not angulated to the ground.
Right.
Maybe that makes sense, isn't it? And then push, rather than trying to push in any other position. So that could be the simplest way, which I learned from pediatric surgeon. These are not mine. So I attended a couple of sessions from pediatric surgeons. So they told us these points, and they are, I think, very useful in practice. The last question, which most of the pediatricians wants to know, PEG you said to give.
Yes.
How long you want to give? This is a question for many pediatricians. I don't know whether you want to give for 2 weeks, 1 week, 4 weeks, 6 months, 1 year.
So, yes.
In an otherwise a simple benign constipation, I would functional constipation.
Okay, so in a functional constipation, our primary aim is first to disimpact. So we need to start with a slightly higher dose of polyethylene glycol at 1 to 1.5 gram per kg per day. Once the disimpaction has been done, we have to.
How long it will take? How long it will take? Give simple words for pediatrics.
It takes around 3 to 5 days of oral therapy.
Okay, for 4 or 5 days, you will give that. Next.
Yes. Then we step down the dose to a maintenance dose because we need to retrain the bowel now. So we come down to around 0.6 to 0.8 gram per kg. Now this pattern, this dose needs to be continued till there is a pattern of soft stools, at least, once every alternate day, at least once a day is the best what we can expect. So the parents need to be told this, because abruptly now if we withdraw
No, that's fine. I want to just again make it brief for you. How long?
Right. So it depends. I always tell the parents somewhere around 4 to 6 weeks is what I always tell them at the beginning. So the compliance is maintained. Otherwise, they feel ek hafte mein disinfection ho gaya, to, then we don't need to give it any further. But that's not
after 4 to 6 weeks. After 4 to 6 weeks, will you stop?
No, we will taper
it. Will you give once a week? Will you give twice a week? At least please tell me. This is an important thing.
I will taper the dose, sir. I will still give daily. I will taper the dose. Get the dose little lower on. Once the dose is negligible, maybe I will omit it after tapering and watch for the stool pattern after that. That's why
in your practice, after tapering, what has happened?
Sir, most of them are passing well stools, but we still have cases where constipation resurfaces, reimpaction also happens. And this happens generally if we don't give them appropriate dietary advice, which I think is an important part and parcel along with the laxative therapy. So yes, I think it's more of a case-based thing. So if they don't,
okay. The last question. I don't want to take drugs. I want diet correction from the mother. What is your advice? This is a very common question asked by all the mothers.
I don't want to take drugs.
Don't give me medicines because I don't want to get addicted. I want only diet. This is. I am the mother now. You tell me, what will you tell?
So I think if your child is constipated and if I feel the diet is faulty, I will tell the mother, okay, we'll try and see if we can correct the diet. But if it's not corrected with the diet, we will have to give the laxatives, and laxatives will help well only once the diet is corrected. So both go hand in hand. One of the thing is not going to help, is what I feel. But in the long run, yes, only diet will surely benefit the child once we get treated with the disease.
Last question to you. When will you refer to pediatric surgeon? This is another question from many pediatricians. Will you manage or will you refer to pediatric surgeon?
Pediatric surgeon. So, sir, any obvious organic cause of constipation will obviously refer, like if there is any suspected neural tube defect or any anal ectopia or any anal malformations, all these are definitely to be referred at birth itself. And after that also, if we are unable to treat constipation, maybe for a year or so, we'll still give a super specialty reference, because the data says almost 10% are intractable and need referral.
What the pediatric surgeon has done when you have referred when there is no surgical cause?
He's given laxatives again.
That's all again, isn't it? Okay, fine. I think, thank you very much, Amrita. I think from the questions I made some important points, and maybe for the faculties for future, let me tell you in 2 lines. Please don't read the subject when the subject is allotted to you. Please write down what 5 things that bothers you in your day-to-day practice or in your ward practice, and write down the answers, whether they are correct or wrong. Read and then don't change your answers. And I will tell you, you will make wonderful presentations. Read only for the sake of it. Make the slides for the sake of it. But I'll tell you, you should speak from your heart and from your experience, and just mix them with evidences. They make beautiful presentations of 5 minutes. So these are my small tips, and thank you, Dr. Renu, Dr.
Sir, one more speaker is there, Dr. Girish Jo. Topic is fever with rash.
Sorry. Fever with rash. Okay.
Yeah.
Fever with rash. Dr. Girish?
Jo, Girish.
Girish.
Yes, good evening, sir.
Now tell me, what is the message for those pediatricians who don't observe rash by not removing clothes?
They should remove clothes and observe, sir.
But where they should observe?
Where, in the sense, total body.
I mean, I will use torchlight, or will you take him to the window?
Natural light, sir. Natural light. Natural light, preferably.
Okay. So that means to say, you should have a natural light and then take them there and examine, right? That's important, because otherwise you will miss, isn't it? Okay, that was, and your presentation was too fantastic. Perfect classical. You finished in time. I have no questions much to ask, but tell me, some creams are available like rash free, itch free, guard free, and all those things. Will you treat them, or will you leave the rash alone for the cause of it? And did you get my question?
Yeah, yes, sir. So, if the rash is itching, then you want me to answer whether I would apply a local cream or would I give a oral medicine? Is that what?
Okay, let me make my questions very specific. Will you give emollient? Will you give anything itch-free, whatever that comes?
Emollients, for a desquamatic rash, I would use emollients.
For a post-infectious rashes.
For post-infectious rashes, I would give emollients if there is desquamation.
Okay, otherwise no.
Otherwise no.
For itching, what will you give?
Either depending upon the age of the child, either cetirizine for a small child, fexofenadine for an older child, and still older, I would use belastine.
You will use belastine. Do you think first generation will help or second generation will help?
First generation would help.
Help, isn't it? That's the most common. I think that's the most common practice. They would use a second generation while first generation are most effective. Do you agree?
I think they have common side effects like drowsiness. So for school children,
so you would categorize whether it is urticarial type, etc. Do you think antihistamines will help in urticaria? This is a very common question by many pediatricians. In fact, don't help, isn't it?
No, don't help.
Don't help. So that's something which pediatrician should take home. And do you use montelukast?
Not really.
I'm sorry, I'm coming to my area, but will you use montelukast, levocetirizine for itching?
No, sir.
No.
Only cetirizine.
I mean, that's a simple answer, right? Okay.
Yes.
I think we are almost done. What I did was, I did not cover what he has already covered. I was just trying to add to if there is anything to be done. Fantastic. This was also good. Renu, you want me to sum up in 2 lines?
Yeah, sure, sir. Yeah.
Okay. I think the good thing was all the topics are fantastic. May I request the participants to WhatsApp to Renu what other topics you want. You know, that makes a, what should I say, topic bank. And you know, that will go a long way rather than the organizers choosing the topic. I think the audience should choose the topic so that, you know, that becomes fantastic. So you can have one theme per session. Now we have symptoms. Next time you can have all top 10 drugs. Next time you can have top 10 investigations. Next time you can have top 10. I mean, something like that. That theme for the day would make it much more meaningful so that, audience will get appropriate messages. For the speakers, you have been wonderful. Make small and crisp presentations. I'm very thankful to all of you, including my own friend, Dr. Devaraj Raichur from my state and my senior, where we studied together. So a lot of regards for you, Renu, and Amol Pawar and Hemant for inviting us, and all the Mahaladies and the speakers. You have been wonderful. Dr. Nanvedkar and Dr. Aarti Madam, you have been fantastic judges, and you made appropriate questions, and it was actually thoroughly enjoyable academics for me. I would like not to miss any of these sessions. I think till Renu finishes the phone, all that you need to do this.
Sir, Dr. Basavaraja sir was there, and I wanted to have him, and he left just now, so he is rejoining. So that's why.
Okay, fine,
Yeah. Sir, you can carry on. Yeah.
All that you can do in these 5 minutes presentation is there are only 2 slides. One is summary slide, second is algorithm. That's all. You just make for headache, you can make algorithm. For rash, you can make algorithm. For constipation, you can make algorithm. For pallor, you can make algorithm. And I will repeat, for AFI also you can make algorithm. Do you agree? 1 slide of algorithm, 1 slide of conclusions. 2 slides are enough. That will, and you can just speak on those 5 plus 5 points. That will make 5 minutes. I think this is all the message that I want, rather than trying to condense and cut, because we don't feel like cutting the slides. We wanted to give more information in 5 minutes. So give less information in 5 minutes and they will be more effective.
Okay, sir. Basavaraja sir, have you joined?
Yes, Renu madam, I am.
Sir, welcome, sir. Sorry, we
you.
couldn't take you. I saw you later on as the things were going on, so we couldn't disturb the speakers, sir.
No. It was very good flow.
So nice of you to join our Maha IP Women's Committee first program Tuesday Tech, sir.
Thank you, madam. Thank you. It was an excellent. Whatever the topics which has been discussed, it was very relevant. Just I was listening to all the 6 speakers. They're really good. So Kaustubh, Amruta, anyhow, we are all Amruta. We are connected 24/7. That was the thing. And Sanjay Joshi sir, it was as usual. Sir was very practical, and Aarti madam also given a very, very practical tips. And Preeti, she's really gave a things, and Joe Girish was also in a good things. So all the topics were very good, Dr.
Yeah. And Prachi was there for AFI.
Yeah, Prachi was there, yes. Aarti madam was as usual very practical and crisp and clear. Thank you, madam.
And Nani Wadekar sir is also there.
Narendra Nani Wadekar. Amol ji, welcome.
Amol, yeah. अमोल तुम्हाला बोलायचं आहे का? हा, अमोल सर तुम्हाला बोलायचं आहे?
Unmute, Amol.
I think he is not in the range. Thank you, sir. Thank you, Basavaraja sir, for coming here.
Thank you so much.
Yeah, and thank you, Dr. Raichur sir, also teachers of the teacher. Actually, he had asked a question, कि adult is having also the leg pain. So what is the cause of that? So I don't know who will answer.
I will answer. If
Yes,
an adult is having leg pains, his partner should press the legs.
Really good answer. Yeah. So over to Dr. Sonali Shirbhate, who is the convener of the Women's Committee for the Thanksgiving event of this program. Dr. Sonali? Yeah.
Thank you, Renu madam. In this bullet train of Tuesday Techs, our fast and furious drivers ran it very nicely. But the conductors, our judges, controlled the train very nicely. Along with the Dr. Subramaniam sir, we enjoyed all his rapid fire questions and the wonderful presence of Dr. Bhave madam, Dr. Baswaraj sir. So I am very thankful to Maha IP President Dr. Gangolia sir, to our Secretary General Dr. Amol Pawar sir for allotting and recommending this program of Women's Wing. Then I am very thankful to the chief guest of the program, Dr. Swati Bhave Madam, Dr. Subramaniam Sir, for their wonderful presence and giving precious time for this program. I am thankful to our wonderful judges, Dr. Aarti Kinikar Madam, Dr. Narendra Naniwadekar Sir, who wonderfully judge and wonderfully conduct all the given inspiration to all the speakers very well. Then I am thankful to our coordinators, Dr. Renu Boralkar Ma'am and Dr. Deepa Firke Madam, for their excellent work they had been doing since last 15 days. And the most important, I'm very thankful to the speakers, Dr. Sanjay Joshi Sir, Dr. Prachi Patel, Dr. Preeti Naik, Dr. Kaustubh Deshmukh, Dr. Girish Jog, and Dr. Amruta Shirodkar Ma'am. Very well, they had executed their presentations. And last but not the least, I am very thankful to the technical team, Mrs. Pallavi from Exposure Infotech for her contribution to this program, because without her it would not be possible. And yes, we welcome the opinion of the Dr. Subbu Sir about the topics to be told by the all the audience to us. So I welcome all the audience to tell the topics in 2 days for our next session program. It will be on the 15th March. So in 2 or 3 days, kindly give your topics to Renu Madam or to myself, so that we could take that topics in our next theme. And surely, sir, we will try it as a theme-based presentations. We will definitely do it. And before that, we will be having our Women's Day program on 8th March. So I'm thankful to all the audience for their wonderful presence for this program. Thank you very much.
Yeah, good night all.